students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyasree, your OBGYN guru. In this video, I'm going to discuss about the rest of the PYQs of the FMGE, right? So let's start with it. Right. A 67-year-old female with hypertension and diabetes comes with heavy bleeding per vaginum. What is the next management? First and foremost, 67-year-old to bleed heavily is completely abnormal. Because 67, you should have menopause. So this is more likely of a postmenopausal bleeding. So understand the combination now. There is postmenopausal bleeding. Although they didn't mention menopause, you might ask me, why are you thinking in postmenopause? Because 67 is an age where we should attain menopause, right? But in spite of that, she has an episode of heavy bleeding. So definitely it's abnormal. Plus they are having hypertension, plus diabetes mellitus. This gives a classical combination of corpus cancer syndrome. So corpus cancer syndrome is where you have postmenopausal bleeding plus hypertension plus diabetes mellitus. So corpus cancer syndrome is where you're going to have a combination of postmenopausal bleeding, hypertension plus diabetes mellitus plus endometrial carcinoma. So as I'm suspecting endometrial cancer, I would like to do first endometrial biopsy. So the answer here will be endometrial biopsy, right? Next question. A lady with amenorrhea and galactorrhea. What is it? Is it a pituitary adenoma, adrenal hyperplasia, 70-alpha hydroxylase deficiency, none of the above? So the classical triad of amenorrhea, galactorrhea plus decreased libido or the infertility is for prolactinoma. Prolactinoma is mainly a type of pituitary adenoma, so we can go with the option A, right? So the classical triad of amenorrhea, galactorrhea and decreased libido and infertility is mainly seen with prolactinoma or the pituitary adenoma. So that's why we are going with the option A, right? A 35 years old with 36 weeks pregnancy comes with a history of 5 convulsions at home. That's too much. Diagnosis made by the doctor is eclampsia. Next management is labetalol, magnesium sulfate, termination, clonidine. So patient having eclampsia, now she has come to you after the convulsions. So now if you want to prevent further convulsions, you have to give her magnesium sulfate. So whenever you have eclampsia, there are 4 steps which you have to follow, guys. First, to stabilize the patient. If there is an ongoing convulsions, what you should do? Make her lie down where she'll not get hurt. So maintain airway, breathing and circulation. Insert 2 wide bore IV cannulas. So when there is an ongoing convulsion, first stabilize the patient. Then you give magnesium sulfate. Then you give IV labetalol to decrease the high blood pressure. And then you will go for termination. Okay? So you have to stabilize, then give her magnesium sulfate, then IV labetalol to decrease her blood pressure, then you have to terminate her. Okay? Next. 34 years old lady with 4 children after 5th normal vaginal delivery. Excessive bleeding after placenta removal is due to. This is so easy, no? So what is this? So you're understanding, they are going to give you clinical scenarios, but if you try to understand, it's going to be very simple. So you have to just understand. Don't be scared of a clinical scenario. Try to understand. That's all. So there's a 34-year-old lady. She has 4 children. So 5th normal vagina. Multi-paras. She's ready for a cricket team, hai na? And excessive bleeding immediately after the placenta removal. That is nothing but PPH. And here more so ever PPH can happen because of the multi-paras history, right? And the main cause for the PPH here is atonicity, right? Next question. 32-year-old lady with twin pregnancy, dichorionic diamniotic. Always the outcome is better when it is dichorionic diamniotic, right? First baby breech, second baby cephalic. What is the management? Now, again, a very good question. You all should be knowing this. So, whenever you have twins, the mode of delivery is decided by the first twin. If the first twin is cephal, you can go for vaginal delivery. And if the first twin is non-vertex, you'll always go for cesarean section. I repeat this point, guys. If first twin is cephal, you're going to go for vaginal delivery, irrespective of the second twin. Second twin is breech, you do breech vaginal delivery. So if first twin is cephal, both twins you're going to do vaginal delivery. But if first twin is non-vertex, you'll always do cesarean section. So here the first twin is breech. So that's why I'm going to go for cesarean section. Okay. So let's see the next question. Absolute contraindication to breastfeeding. This has been asked many times priorly. So what are the absolute contraindication to breastfeeding? Galactosemia is an absolute contraindication to breastfeeding. HPV, CMV are not contraindications. So what are the absolute contraindication to breastfeeding? When mother is on IV drug abuse or excess alcohol, female undergoing treatment for breast cancer, mother on anti-cancer drugs like methotrexate, active herpes infection on the breast, untreated pulmonary tuberculosis, galactosemia or congenital lactose intolerance. Hepatitis B and C infection is not a contraindication to the breastfeeding. Once the baby receives the immunoglobulin and vaccine, baby, you can start the breastfeeding to the baby, right? So it's not a contraindication. Even HIV is not a contraindication to breastfeeding, right? So what are the contraindications? When they are using IV drug abuse or excess alcohol, undergoing treatment for breast cancer, on anti-cancer drugs, active herpes, untreated pulmonary tuberculosis, galactosemia. So that's why the answer will go here for galactosemia. Lymphogranuloma venereum is caused by. So this is one of the painless ulcer. Lymphogranuloma venereum is mainly caused by Chlamydia trachomatis L1, L2, L3. L1, L2, L3. So syphilis, Treponema pallidum causes syphilis. Herpes simplex, HSV ulcers are painful ulcers. Klebsiella granulomatosis. This causes soft canker. This causes granuloma inguinale. Whereas Haemophilus ducreyi causes chancroid or the soft canker. Haemophilus ducreyi, chancroid as well as HSV are painful ulcers. Whereas lymphogranuloma venereum, granuloma inguinale and hard canker by the syphilis or Treponema pallidum are painless ulcers. Okay? Right. Lady with vaginal discharge, whiff test positive, clue cells are seen. What is the drug of choice? Now, this is very important. So, where do we see whiff test positive and clue cells? This is nothing but the bacterial vaginosis. So, bacterial vaginosis is due to the alteration of microflora by the Gardnerella, Mycoplasma, Peptostreptococci, mainly Gardnerella, right? Ureaplasma, Ureolyticum. There are so many I can quote, but mainly it is due to alteration of the microflora by the Gardnerella. So, bacterial vaginosis, mainly we have the pH will be more than 4.5. Dirty white foul smelling discharge. We will see dirty white foul smelling discharge. So pH will be more than 4.5. We will have dirty white foul smelling discharge. And when you put 10% KOH, you'll have fishy odor. When you put 10% KOH, you'll have fishy odor. And this is called as whiff test positive. And you'll also see clue cells. So clue cells are the bacteria attached to vaginal epithelial cells. Clue cells are bacteria attached to vaginal epithelial cells. Okay. So it is the alteration of microflora of the vagina by Gardnerella, Mycoplasma, Peptostreptococci, bacteroids. You'll have dirty white malodorous discharge, and this is not inflammation, so there are no lymphocytes. So Amsel's criteria is what I was telling: dirty, white, foul-smelling discharge. You should see pH should be more than 4.5. 10%. When you put 10% KOH, you'll have fishy odor. That's called whiff test positive. Clue cells, more than 20% clue cells you should see. More than 20% clue cells you should see. Right? So drug of choice is metronidazole. Drug of choice is metronidazole. So this is how the clue cells will look like. Laparoscopic chromoperturbation is done by methylene blue dye. Methylene blue dye. Remember, okay? And this is the gold standard method for checking the tubal patency. This is a gold standard method for checking the tubal patency. Right? Next question. Patient was advised to take pregnancy tests regularly for molar pregnancy, fetal viability to identify the gender. Obviously, no. Post-molar treatment, we ask them to check the pregnancy, ask them to check the beta HCG levels frequently to see that she is not going into development of choriocarcinoma. So I think this question is more favorable for asking that where do we do follow-up. It is mainly done in the molar pregnancy. So in patients with molar pregnancy, we do beta HCG every week till nil and 3 consecutive weeks. And we'll do every month for 6 months. Every month for 6 months. Okay. Previous neural tube defect, amount of folic acid you have to give to prevent NTD in this pregnancy. So that is, they're asking what is the therapeutic dose of folic acid. So I don't have the option of 5 milligrams. So obviously I'll go for the option of 4 milligrams. So when they have a previous neural tube defect, again, how much amount we have to give? 4 milligrams as per WHO, 5 milligrams as per India. As I don't have the option of 5, we are going to go with the 4, right? So these were some of the MCQs which we had in the, which I wanted to discuss, right? All the best, guys. Keep reading. You're all going to do awesome. OBGYN is easy. And I hope by now you have got a very good grip of OBGYN. And I'm always there for you to help. So myself, I'm Dr. Ramyasree. Thank you so much, guys.